one of, I know Dr. Gopal through St. Luke's has done it, but other than that, I don't know of anyone else who's doing it at all, or who part of it is getting approved through some of those hospital systems to do it. Luckily here at Doc, they're much more willing to kind of tailor to what I can and want to do. So we're going to do two things. One, just go over this, what TENEX is a little bit, and then some time afterwards. Did we bring the other ultrasound machines? We just have one.
Mm-hmm.
So we're just only be able to get one ultrasound machine here. So we can go into our procedure where I have my ultrasound machine. If you have questions about ultrasound, just anything. I don't have anything specifically about ultrasound that I was going to do or anything, but it's more of just open, hey, you want to look at something, want questions about it, happy to kind of look with ultrasound, some of the stuff afterwards, as many as you don't have to stay for that. So for this, we're just going to kind of go to what it is. Is anyone somewhat familiar with what it is? I know I've sent a bunch of patients about post-op, but you probably looked up what it is from that. So to briefly go over why I'm doing this procedure, it really is based off of the disease of the tendon, right? So real quick, I don't want to spend, you guys all know this, most of you know this. So the difference between tendinitis, tendinosis, tendinopathy, really time frame where tendinitis is usually just an acute inflammation. You'll see patients overuse weekend warrior, get a little tendinitis, you calm it down, rest it, it feels a little better. But when that process of overuse occurs over a long time, you start to get tendinosis. Usually they're going to have more than 3 months of pain. You're going to get actual changes in the tendon structure. You're going to get disarrayed tendon fibers, some myofibroblasts, and the tendon actually becomes thickened. And so you'll see that, I'm sure you've seen that with patients. Achilles tendon is a really easy one. Mid-substance will get super thick. And so what we're treating with TENEX is really that tendinosis and tendinopathy, which includes other things like calcific tendinitis, other things where there's just disease, chronic disease tendon. Okay, so the goal of TENEX is to treat that poor tendon tissue, okay, and just debride it, clean out the disarrayed fiber, all the extra collagen fibers, all this other tendon tissue that's just creating pain, some of that neovascularization that occurs in that tendinotic tissue. So this, I like this figure just because it shows that. Just real quick, it shows that there's these disarrayed fibers, you get these neovascularization, you get some extra matrix proteins, whereas you have nice tightly bundled fibers in a normal tendon tissue, your tendon starts to look like this instead of nice tendon tissue. On ultrasound, when you look at it, you're going to get that thickened tissue. I don't have a normal here, because this is pretty normal, getting the edges over here. But when you get that ultrasound tendinosis look, you're going to get that really dark, where those arrows are, that really dark tissue there on transverse views, kind of scattered, darkened tissue throughout the tendon. So that's what tendinosis looks like on ultrasound, okay? At least a fairly good example of it. If you turn on your color, you get neovascularization. All those on the normal tendon, when you turn on color, you should not really see any vessels at all, honestly. Maybe on the periphery we get some vasculature, but within tendinosis, you're going to see this high, this is pretty significant, but you're going to see significant neovascularization within the tendon fibers, which really shouldn't be present. So that's another diagnostic value with tendinosis and ultrasound. You're going to see a lot of that. Now, the TENEX, what is it? So really the TENEX is the little device. I brought a couple tips there in the back that you can look at, and just be careful because they are actually real tips. So if you take the cap off, it's a little sharp on the end. But you can take a look at it, see what it looks like. So TENEX is that device. It's the micro tip device that I use with the machine, which is this guy over here, which is plugged in this machine for some settings. This is the cord.
Can they card on there too?
Huh?
Can they credit card on there too?
No, I wish. So it has the micro tip here, and it has tube connected to this thing here, which connects to the machine. This is has a bag for the fluid, and so fluid is going, and we'll have other slides with this, but fluid goes in through my device into the tissue, then is suctioned back into this bag. So when you have things like calcific tendinitis, you actually will see the calcific tissue, calcium deposit, kind of be flushed out and into the bag and some things like that. So this device, it is a combination of irrigating the tissue with that fluid. It cuts through poor tissue and aspirates all that material that you're kind of breaking up. The nice thing about what they did was tailor the vibration, because it's really ultrasonic percutaneous tendon. It's using ultrasonic technology that vibrates a certain frequency, so when I'm passing through tendon tissue, I'm not just cutting the tendon, right? I'm passing longitudinally, and you always do it longitudinally, not transversely through the tendon, longitudinally through the tendon, so it'll pass through really nicely through those fibers and debride all that extra tissue between the fascicles of the tendon. So why am I doing this? One, when do you do this? This is a rather popular question. Why do you do TENEX? Why are you going to refer someone to TENEX? You know, they've been your patient, I'm sure you've seen this, been your patient for 3 months, 6 months, and they have these chronic tendon issues and they're just not getting better because it's a tendon and it's a 4-time healing. You've tried other things like dry needling, you scrape the tendon, you've done all these things. So people with chronic tendon pain with diagnosed tendinosis or calcific tendonitis, okay? Clinically, you know, I like to be able to see it on ultrasound. Sometimes people with small partial tears, you can do this too, just the torn small tendons. And then after failure of conservative management, if they've done rest for, you know, other basic stuff, tried physical therapy. I don't love steroid injections in tendons, actually. I don't really taught in medical school and things, you know, residency even, you know, TENEX will just inject with steroid, they'll feel better, which it will for probably 3 months, and then they'll come back, and then now they have this chronic tendinopathy. So I don't like to. Some patients really try to convince me to do one, and I'll do the one steroid injection near the tendon, but I don't really like steroid, especially for elbows. PRP I do quite a bit of, and it does work for tendinosis. I do that a lot, and it's a fairly good treatment. But sometimes for cost issues, I don't want to pay cash for that, and also it hurts when I do PRP. I do fairly good amount of leukocyte-rich PRP that really is painful, and I've heard that it actually hurts more than doing a TENEX procedure. So the post pain. You also need to have more than 3 months of symptoms, which technically really is tendinosis. If it's less than that, you really want to try to continue conservative treatment before they're considering doing something like this. Before I'm going to do it, I really want to be able to see that under ultrasound. I'm going to ultrasound everyone first before I do something like this. So if you guys, if you diagnostic ultrasound, if you've seen that, that's good to like send me a referral and say like, oh, they ultrasounded it and they gave me, you know, diagnostically they were able to see it. So how is it performed? So they make insurance makes me do this at a surgery center. This is simple enough that I with the cash payment patients, I just do it right here in my clinic, okay, in the procedure room. There's enough space. If I have my machine, TENEX machine, ultrasound machine, you can cleanly prep it and you should be able to do it in office. But insurance won't pay for it for me to do it. So there is option for patients who want to just pay cash to do it, to just do it right here. It's really simple. But usually it's done at the surgery center, Treasure Valley Hospital usually. Oh, by the way, if you guys have any questions, interrupt me, okay?
I have a question.
Yes.
What is the cash pay cost?
I think we put it at like $2,250,
Okay.
something like that. That includes the visit, the procedure, everything. It's just like 1 month payment and everything's done. Yeah.
MRI is not required.
MRI is not required.
Okay.
No. It may be required on questionable cases or if it's not just clearly one tendon or something like that, but most often with tendons I'm able to do this on, ultrasound diagnostic, I can diagnostically look at an ultrasound. One exception may be hips, which is a kind of a harder one. I don't do much for 2 reasons. A hip, for most people, it's pretty, like when I say hip, gluteal tendinopathy of like glute med, glute min, it's hard to see, hard to get to, one, so I don't have the microtips that we currently have are long enough to reach. They're actually coming out next year with a 3.5-inch needle that I should be able to start to do hips for. But to your point of MRI, sometimes that's better diagnosed on MRI if they're really big. It's hard to see deep into that tissue sometimes, but it depends on the patient and the situation. So those are the one situations where I don't mind MRIs on some lateral hip stuff. But gluteal tendons too, I can usually see that pretty well, but you can do it on like a proximal hamstring is what I mean. So, all right, so back to this. Done at the surgery center. Currently, yeah, I do it at St. Luke's too, but I don't like to do it at St. Luke's. So St. Luke's people here, right? So, done under local. Okay, there's no general anesthesia. That's kind of the benefit. One of the benefits of this is I will sometimes give people like oral things for anxiety, because obviously if they're awake while I'm doing something, some people get a little anxious about that, so I'll give some medicine. But otherwise, it's simply just local anesthetic with lidocaine, some bupivacaine, locally numbed up around and into the tissue, and they shouldn't feel a darn thing when I'm actually doing the procedure. And then I make a small skin incision, like just enough to get that needle tip in. So it's usually like 3 or 4 millimeters big. I don't even do sutures. We're just going to do a stair strip over the top to be able to let that tissue come back together. And so it's pretty simple, and recovery is much easier because no general anesthesia, minimally invasive small incision, and just local anesthetic. Okay. This is a video, so you can kind of just use the TENEX video so you can kind of see. Maybe they'll explain it a little clearer than I just did.
Powerful, precise, life-changing.
Dramatic too.
The TENEX Health TX system and TX Microtip, a minimally invasive single procedure treatment option for pain-causing bone, calcific, and soft tissue with rapid healing and less discomfort than open surgery in soft tissue. TX Microtip features advanced ultrasonic technology, typically paired with image guidance, to enable precise cutting and removal of symptomatic bone and soft tissue percutaneously through a 3mm incision. TX Microtip provides relief for a variety of chronic conditions all over the body. A simple outpatient procedure takes minutes under local anesthesia. Saline flows from the outer sheath, while broken down tissue and saline are removed through the inner needle, sparing healthy tendon while cutting and removing symptomatic soft tissue and bone. Closing typically requires only a small bandage instead of sutures.
Alright. It's kind of how it works. Which is that easy to see, but it's kind of how it works. So I was supposed to, yesterday, I did a group of TENEX procedures, have a video of me doing one of these, like the actual ultrasound look to it, but we got so far behind, we run so behind, I just never got around to making it. So I apologize, but this section was, I was going to show you, this is I think Olivia's tendon right here. Looks pretty good. Just quickly threw it on and off this, but here's her lateral epicondyle, their common extensor tendon, pretty homogeneous tissue there, no real change, no significantly dark tissue. I mean, you could say that there's maybe a little bit of things here, but compared to something with obvious tendinopathy, there's a lot of tendinosis, darkened tissue, a little calcific tendinitis, very little, really dark here. You know, it's hard sometimes to differentiate tendinosis through like partial tear, but that is definitely unhealthy tendon compared to nice, even look to this tendon here. So anyway, that's kind of what it looks like. What I was going to show is a picture of, an elbow I did yesterday, and you basically have the tip pass and break through this tissue, gently back and forth, come through all this tissue slowly, and make sure you pass at least through all that poor tissue. Yeah?
How does it work if they have a vesified or bone spur?
I'll
You
grind
can
it out.
vesify with
There's 2 types of tips. Here at this up, we just have the one. There's that, what's called the TX2, which is a little bit longer, a little skinnier, and really better for like there's the tendon tissue. And there's something called the TXB, which is thick, a little bit thicker bore needle, but it does a better job with thistophytes, osteophytes. Especially I do a lot of Achilles, partly because it's a big issue, insertional Achilles tendinopathy. The surgery for Haglund's deformity on a huge spur off the heel is pretty invasive. If you do it surgically, they're just going to cut you open, they're going to cut out the spur, they're probably going to take off regraft tissue. There's just a big, huge, long recovery. So I do my best to on those ones, actually grind back with the TXB, the Haglund's deformity. But in my mind, the bigger issue is the tendon caused the spurring, and so I treat the tendon mostly, right? So I'm treating the tendon, make sure I get through all that distal tendon that's usually real thickened, and the Achilles tendon, that you can kind of, when you're doing this, like if you need draining, there's a lot of feel to it. It's when I pass them through normal tendon tissue, especially when you have the device on, it passes kind of like butter. It just kind of goes through that nice tendon tissue, passes through the fibers. When they have bad tendinosis, especially with calcified tendons, it's like, it's firmer than an overcooked steak. It's just like hard even to pass it through. So you pass it through back and forth a lot to break it down. And at the same time, I kind of try to shave gradually down that bone spur. And it will work. If it's big enough, it's going to be really hard. And I can promise the patient, I can try to treat the tendon a little bit, but I'm probably not going to be able to remove that spur completely. But it is a much more aggressive treatment to have an open surgery to do that. So I just tell the patient, like, this is a much quicker recovery, safer option, and you probably do better, but you probably still have a spur there. But if we treat the tendon and then do the rehab to where that it's all better, you get better, then you're probably not going to have the same level of pain you had. So Achilles tendon I do a lot of because of that, and we have Dr. Ken Footnagle, surgeon too, and so I just see a lot of Achilles. People see him and don't want to do with 9-month recovery surgery. So,
Is there much risk for tendon rupture?
No, I was going to get that. Zero, really, if it's done correctly and the rehabs follow, the protocol afterwards is followed. And this was, I think, 5 years ago when I was learning about and doing TENEX. Initially, there had been 1 or 2 cases out of hundreds of thousands that had an Achilles tendon rupture, and that was the only ruptures they had was something on Achilles tendon. In both cases, the patient didn't follow the use of the boot. They just kind of afterwards started walking around or probably jumping around. So the risk is not zero, I guess, but it's very, very low. I've never had any issues with that. And in studies, hundreds of thousands of patients, there's been if not any ruptures. So someone else had a hand up.
I had the same question.
Same question. Yeah, so as long as you're passing logically through that tendon, not really cutting across tendon fibers, and then like the patients, they'll show you here, patients should follow some immobilization for a brief period before they're moving. So areas, really any large tendon. Tendon's too small, you really can't do it. Like your peroneal, posterior tib, peroneal tendons, too small. The common extensor tendon is probably the smallest tendon we do. And it works pretty well at the elbow, easy to do, so it's superficial. As it's a really common problem, I think it's really good for tennis elbow. Other areas, shoulder, hips. I talked about the hips. One that doesn't really point to, but you can do proximal hamstring if you can reach it. A little hard on that one, but especially when they come out with a longer device, I should be able to do that much easier. Knees, you do a few knees. Knees are hard, but as far as knees just outcomes, I don't think they're still good. It's a better treatment than having, again, an open debridement of like your patellar tendon, but I don't think they maybe do it quite as well as an elbow, plantar fascia or something. Plantar fascia is a real good one. Like we're essentially debriding out plantar fascia, loosening the fascia. A surgeon's just going to go in there and snip the fascia off anyway if he does a fasciotomy. And so I'm kind of doing a mini fasciotomy when I do this. That's the one where you'll probably come, not necessarily because it's not really tendon tissue, you can come transversely across the foot and just go through the fascia, debride the fascia, their pain goes away. So that's really a quick recovery for plantar fasciitis.
Are you doing mostly on the patella tendon distal, like tibial insertion, or you do need
No,
patella
usually
too?
most people have
What,
proximal.
proximal?
Most of that's
what
younger
I'm seeing
patients. Patellar tendinopathy really is from the overuse athletes. Like I did one on a 14-year-old girl who had severe proximal. That's sad at that age, but severe proximal tendinosis tendinopathy with a little calcified ossicle within the tendon at their proximal tendon, and I did hers.
Okay, good to know. Yeah, I wasn't sure on the proximal too.
Yeah.
What about the shoulders, like the supraspinatus tendinosis?
Yeah.
Even without calcific tendinitis, there's like
Yeah, I do it
patients are
for
in between,
shoulders.
like needing surgery and not.
And then there's nothing to repair. Yeah.
Okay.
So that's good for shoulders good. It's again shoulders kind of hit or miss if it's a really large patient. You're not gonna be able to get down to there. So there's that limiting factor for now. But if it's really totally fit, easy to get to kind of shoulder. Some of the bigger guys with big deltoids are hard to get down to that. But for tendinosis of the shoulder. Most of the shoulders I do are calcific tendonitis,
Mhm.
honestly. That's a big one where, you know, it's easier to breathe that way than to open up, and a lot of times they'll cut out and then do a repair if they're doing large calcific tendonitis, but this works really well for that. So yeah, if they just have chronic tendinosis.
I know you do barbitage too. Would you try to barbitage the shoulder first?
Yeah, I'll
before doing
talk about that at the end here. I'll put some stuff on barbitage because
TENEX?
jump ahead. No, just because that's when I typically end up doing, because I do so much barbitage for shoulder for large deposits. If it just doesn't go away all the way, those are the patients that typically will get TENEX on the shoulder.
Is there like an upper age range for this?
I've done. She was around 80, I think. Young wise, they just mature, be able to tolerate something like this. The girl I told you, 14, she was real brave. She did a good job. There might be a few tears when you're kind of getting going and everything that's expected with something. They just get real nervous. I don't think they'd be as nervous as I'd be able to do in office because it's so much. But you're like in the OR, and you're just in this room in a gown. It seems very formal and like we're gonna cut her open or something. But it's but yeah, as long as they're able to tolerate it, as far as age-wise, young-wise, I'm fine doing it. I prefer they're skeletally mature. Not dealing with a lot of growth plate issues. That girl was mature, skeletally mature and grown. But otherwise, old age-wise, obviously the higher up they go, sometimes a little harder recovery. So I look at just overall health, if they're able to do the rehab, move, what their overall condition is like. But you know, for some of these, I've done 70-plus-year-olds that just have bad tennis elbow and just hurt forever, and they just do this and really breathe it, and they feel better. So, yeah. So I didn't put a ton of actual research in here. You're welcome to look it up. You can go to their website. But it's not like this is brand new and we don't have any information on it. This has been around for a long time now, 10, 15 years probably, and with a lot of data behind it. At this point, you know, there's 100 plus good independent studies and lots of good clinical outcomes reported. So you can go. Trice is actually the company who makes the TENEX. So Trice is where you probably go to find any of that information. But I didn't really directly put that here. So for the afterwards, okay, after TENEX, and you guys love your therapists. You're seeing them after I've already done all this. You've never seen them before, and I send them to you like, here you go. Rehab this patient. So usually for most bodies, you're going to rest the body part and the joint for 1 to 2 weeks. If usually a boot, if it's a foot around like the Achilles, or a brace. I like wrist braces for the elbows just to keep them from just over gripping, overusing, just for a week or two. They're supposed to come out of their mobilization to do early range of motion. It's in their little post-procedure paperwork that I give them. So you can do early range of motion, but they should be protected for the first week or two. I usually see them back between 1 and 2 weeks in my clinic to take a look at the incision, make sure everything's good. Then I usually write them a therapy prescription and send them to you guys. If they've seen therapists before, sometimes they'll get that set up with you, so they start right at 2 weeks would be ideal, but that's not always how quickly it works. But I usually give everyone, I'll print out more I can. I just put the paper over there that's on the table, but it's as an example of one. But it really just says it's the guidelines for the procedure. It has all the patient information, but it also has really the therapy kind of process in there for them as well. There's a few patients that refuse to go to formal therapy, so I will at least try to guide them in that too. But it's really the best thing to follow. I mean, if you guys really want me to, I could make a more formalized version, but I think the patient one has, it says it's week by week. Week 2, start isometric exercises. Week 4, add in, this and that. So it just has for each body part, and there's one for each tendon that I do. There's one for Achilles, there's one for shoulders, and the patient would have it with them, and they bring it with them to you, and you could look through their rehab there. But in general, this is kind of how it goes, right? So overall, we just want to gradually load that tendon back to tolerance. And obviously, strengthening everything around that. You can begin early strengthening of muscles around the tendon. I'm a pretty big proponent of blood flow restriction for this, especially because a lot of patients have high levels of pain. So if you can load the tendon at a lower level without them and still get a better effect, that's fine with me. I'm okay doing blood flow restriction. Don't do any dry needling, scraping of that tendon, please, for at least 6 weeks until like a lot of that remodeling starting to happen. If you want to do it surrounding muscles and things for pain and things like that, especially dry needling, that's fine. Just to the tendon, the tissue itself, I prefer just let it be a good thing. And then you're going to gradually progress to higher loads. Isometrics early on until it's really minimally no longer painful, and then you can start with some slow eccentric isotonic exercise, and then progress from there. I put next slide. So I really am okay with them returning back to their normal daily activities as long as they're not overly painful to do, right? We're going to hold off on high loading sports athletics for a while, depending on the body part. The elbows will respond pretty quickly, and so even at 6 weeks, sometimes they're like, I have no pain, I'm good, good strength, and they can start to resume activities in sports. Things like Achilles, shoulders are going to take longer. Those, I tell patients usually, I'm like, it's going to take 3 months for you to be better, but still, usually they're better a little sooner than that, but I give them kind of expectation that on a big tendon like your shoulder or your Achilles, it's just going to take time for it to feel all the way better. But again, return to sports or athletics or activities really varies. 6 to 12 weeks is probably a good time frame there. Any questions about all that?
Most insurances pay for this.
Yeah, there's a few that drag their feet, but I haven't have any that just always deny it. It's pretty well covered.
I got a question.
Yeah.
If somebody has PRP, what's the interval between PRP and considering TENEX?
After I do PRP, I almost always wait to do anything else for like 3 months.
Okay.
Because I think can be a slow and gradual improvement with that, especially when I do like 4 or 5% leukocyte-rich PRP on patients. It gets really painful at first, so they really drives up their pain. And for that, sometimes they calm down, plus have the improvement after that. I just time, and so I'll probably do 3 months, maybe 6 weeks at the soonest, but really I think 3 months is probably what I would recommend.
Would you do the same for if someone had a steroid injection as well?
I did at least 6 weeks. That medicine's probably not around that 6 weeks point. At that point, it's usually people still feeling good the effects of the steroid, but the medicine's gone. If you do it before, you'll see that catalog or you'll see it in the tissue still. And so we'll wait until that's at least 6 weeks. But that comes up too sometimes. People are just like, I just need something like a shoulder, especially. I just need something that hurts really bad. And you guys, we'll talk about this, but you can do a steroid injection. But if you do it, yeah, you're gonna have to wait at least 6 weeks before you do something else, like a TENEX. The other things about TENEX questions right now. I'm gonna talk a little bit about barbitage, and then.
Is there a body part it's most successful at that you've noticed?
So studies pan out, and what I've seen is elbows are pretty successful. Okay, plantar fascia. All my plantar fascia patients have done really well. That's one that I was actually surprised about. Just because I think you're really just truly doing a fasciotomy, and that makes it feel better. What else is pretty well? Those two for sure are the best. What I typically say with something that's harder, like an Achilles tendon, especially insertional, mid-substance Achilles does pretty well. Just don't see it as much as insertional. And a shoulder, I sometimes say, probably about it, their studies found there's about 80% success rate on their surgeries, maybe a little bit better, higher than 90% in something like an elbow or plantar fascia. And a lot of those patients in that didn't get better 20%, are better. They still have some pain, but they're better than before the procedure. So there's sometimes like clarifying expectations that you'll most likely be better, but you may not be 100%. But someone who's been dealing with 2 years of insertional Achilles pain, sometimes they'll take that because it's just been, especially with that's really bad Achilles tendon. All right, so real quick about barbitage. Have anyone not heard of what like the barbitage is? Nowadays, people know. So when people have a large calcific tendon, usually it's the shoulder because it's most common and it's easy to get to. It doesn't really work super well in Achilles. I think the tissue's too firm. But essentially, when someone has a large calcific tendonitis, especially in the shoulder, like supraspinatus, you can in office get a needle down to the tissue, numb up this right to the deposit, get a needle in the deposit, and then essentially rinse out the calcium. Okay, so this is my first patient, and you can see this is my needle here. This is the deposit right here. This is the supraspinatus tendon, and you can see it's kind of pulsing because I'm pushing fluid into this deposit, and it kind of blows it up a little bit like a balloon, and use the vacuum pressure in there. But that's when you put the fluid will come back in and taking the calcium with it. Okay, so you can see here, I don't know if you can appreciate here, but you can see this puff of calcium. See that right there? So literally just calcium coming out of the shoulder in that manner. Okay, so it works really well for large calcium deposits in the shoulder. Okay, but it has to be large because I need to get, this is an 18 gauge needle here. Okay, so I need to get a large bore needle into the deposit. So if it's too small, so like this, that guy. Sometimes I'll get a patient from, and I'm not pointing any names, those are great, great thing. But it'd be like, consult Dr. Neilson for barbitage, and then I'll look at that x-ray and I'm like, what am I supposed to do with this, right? So those cases, this is just too small. That's probably just a few millimeters in size. My 18 gauge needle is probably that big. So these patients, just for the PAs, when you see something that says small calcific tendonitis, one, make sure it's definitely the calcific tendonitis that's bothering them. Okay, do a good exam. It could be adhesive capsulitis, could just be subacromial bursitis. And a good option for PAs is you can do a subacromial injection on these right away. Like if it looks like it would be an appropriate treatment. Because I'm not going to do a barbitage. If we do an injection, that's probably the best first line treatment anyway. You can do a TENEX on this, right? If I do think that just right there, that little thing continues to be bothersome. And usually they're going to have underlying tendinosis, tendinopathy if they have that little calcium anyway. So once they're feeling better, then if it starts bugging me, and then they can come see me, and then I can do a good little set evaluation, look at the tendon, and see if something like TENEX is an appropriate treatment, right? But what happens on these all the time is I get them in my office after the consult, I look at it, and then I just do a steroid injection, and maybe some therapy if I think they have some underlying tendinopathy, right?
And a future TENEX patient.
Possibly, right? Honestly, what happens mostly is I do a steroid injection, I send them physical therapy for 6 weeks, and then they're good.
If they go to active,
yeah. If they go to that's our problem. So don't send me that. Say this is a TENEX consult, okay? So this is more something like you would see. That's going to be a TENEX or a barbitage. Barbitage is what we're talking about here. So barbitage first. So this is one where with ultrasound you get on ultrasound exam you have a nice tendon, then you got this big hyperechoic pebble looking, it's round, sharp, white line, and then a big shadow underneath because the calcium is creating that hypoechoic shadow. So you need it to look like that in ultrasound. It needs to be big enough. You need to have this particular look to it so that I know it's a ball of calcium that if I go in, it's going to create that vacuum effect and be able to work for a barbitage. There's some calcific tendonitis that is just calcium strewn through the tissue, and you can't barbitage that. That's really a TENEX procedure. So it has to look something like this, where you get like a collection of calcium into the shoulder. So yes. So those are TENEX type of things. Okay. All right. Any questions about any of that?
What's the recovery for the barbitage?
Barbitage?
I mean, like.
Well, when I do barbitage, I'm really disrupting that calcium in there. And so I do a little in the bursa afterwards. I'll come back and put a little steroid in the bursa. Otherwise, they're going to get that 10 out of 10 calcific tendonitis pain. So I do it, and 3 days later, they feel like 100%. So those patients are actually like, please slow down. More and more, I try to get people to do therapy afterwards because obviously they've had this big calcium deposit in there. It goes away, and that tendon probably could use a lot of rehab. A lot of patients don't because they feel so much better. So it's this balance of like, it's going to feel a lot better. And it's hard because a lot of those patients, they feel perfectly fine. They don't have any shoulder pain. All of a sudden, short starts to hurt a little bit, and they have 10 out of 10 calcific tendonitis type pain. You guys see it all the time. They come in and they can't move their arm, and they have this bad calcific tendonitis. And so as soon as you resolve that inflammatory response from the calcium, they feel back to 100%. And so they don't want to go through full therapy. So a lot of people end up with exercises to do at home, and then you most wonder if they do that. But they'll feel better really quick. I have them back in my office 2 to 3 weeks after I've done that, which is actually covered in the full code for the barbotage, so they don't get billed again actually. But they come back in and I do a good cuff exam to make sure they're not weak and things like that. I'll do a full exam to make sure they're not showing signs of tearing or anything.
So do you want them to start PT as soon as TENEX or wait longer?
For
barbotage?
Yeah, again, that's why I see it about 2 weeks after, because then I'll have to determine, like, I'll send them for a PT after that. Yeah.
With TENEX, do you ever have people come back like a year post, 6 months post, and do it multiple times, or is it?
I don't typically will do it again on the same exact spot. Usually, if they come back, the most common is, again, an insertional Achilles, which just had really bad Haglund's, bad thing. We tried our best. I've sent like 2 out of, we've been doing this now 3 years, 2 patients for the Achilles. I've had to send to like Dr. Kim, foot and ankle, who probably did a more reconstruction surgery on that. But it is uncommon. So yeah, I mean, most patients do better enough, and then I think with time it just feels better, and they just forget better. There are those cases, like I just had one case with a young guy who had a bad mid-substance calcific tendonitis of his Achilles. I did that, and now he's come back. Now his insertion hurts. He has insertional, too. He's one that really didn't do great with rehab and everything. He really didn't go. But yeah, so there are those that I'll probably do it in the same tendon if it's not quite the same thing. Okay. All right. Yes.
What's the best way for us to send a patient for you? I guess in terms of ultrasound, would you want a fax of like a whole ultrasound report, or just like a
Yeah, if you've done a diagnostic ultrasound on it,
Okay.
you show, hey, there's some good tendinosis here. Just have them schedule with me. Like, easiest way is probably just have them call directly into my office. And I have, if you guys want my cards, I have a stack of probably cards I can get you guys. And then call line, have them schedule with Dr. Neilson as a new patient, and just have them bring anything you have for them. Yeah, I mean, if they all set up like that, I see them, like if I'm doing TENEX soon, I'll just do it right away. I had a patient actually came in Thursday this week, really bad chronic tennis elbow, and then that was Thursday, and then yesterday I did her TENEX. So it can be done quick. The one thing sometimes, well, I'm only scheduled like do these once a month because there's just not that many, but it's usually about 4 or 5 a month, and I'll stack them on one day. So I'm usually doing once a month. But the hope is there's enough patients, and I know there are enough patients in Valley with only me doing this, that I could be doing it, twice a month, so I could get patients seen and treated sooner. But right now, sometimes people come see me, early next week, and I'll be like, well, I'm not doing this until mid-January, right? Normally, those patients have been dealing with this issue for like 2 years anyway, so they're okay waiting a month or 2. But that is the case. It's done like once a month right now. Okay. All right. Thank you, guys. There are, like I said, there's a little TENEX device back there. If I want to take a peek at it, I guess we can. Do you want to roll the ultrasound over here?
Yeah, I can do that.